Hello everyone. So today I'll be talking about upper gastrointestinal bleeding and its management. We start off with an algorithm for the management of a UGI bleed. So when a patient presents with UGI bleed either in the form of hematemesis or melena, we first have to assess if the patient is stable or not. So first I'll be talking about what to do if the patient presents unstable. So unstable as in I mean the patient may be in shock, with a hypotension with an SPP less than 90. So in those cases we have to first stabilize them. So first step is to monitor airway breathing, provide supplemental oxygen if the SpO2 is less than 94%. Very important is to immediately place two large bore IV cannula and start IV fluids. We prefer crystalloids like NS, normal saline, and or Ringer's lactate. Then we collect blood samples and send for investigations like complete blood counts, hemoglobin, PTINR, LFTs, type and cross match, blood urea nitrogen, and creatinine levels. And if the patient has very severe bleeding, ongoing active bleed with the risk of aspiration, then you have to intubate the patient. And you can also place a nasogastric tube and suction out the contents, and in case of active bleeding you will find bright red blood, and placing a nasogastric tube usually helps remove any blood clots that may be present. And also we have to start pharmacotherapy. Now pharmacotherapy, we give IV proton pump inhibitors like pantoprazole or esomeprazole 80 mg IV. For all patients with bleeding, we have to give PPI, while medications like octreotide and prophylactic antibiotics are given for suspected variceal bleeding. So we give IV octreotide infusion for known or suspected variceal bleed, 50 microgram IV bolus followed by 50 microgram per hour as continuous infusion. We also give IV antibiotics, either IV ceftriaxone or fluoroquinolone. Now, just a note here, instead of octreotide, other options are all, include terlipressin, which is a synthetic analog of vasopressin. Now, after all of these measures in a hemodynamically unstable patient, once a patient is made stable, the next step is to take a quick assessment. So we basically do a history and a physical examination. For example, we ask about the history of alcohol use, prior GI bleed, history of liver diseases, medications that the patient may be taking like NSAIDs, aspirin, anticoagulants, and antiplatelets. These increase the risk of bleed. Any history of abdominal pain or melena, because the presence of recurrent abdominal pain points out to the presence of a possible peptic ulcer. And on physical examination, you look for tachycardia, hypotension, severe abdominal tenderness with guarding and rigidity. Now, if these are present, it strongly denotes perforation of, for example, a duodenal ulcer. Now, we also take this quick assessment because there are some factors that make an upper gastrointestinal bleed more likely than a lower GI bleed. Like, for example, history of melena, coffee ground vomitus, a blood urea nitrogen to creatinine ratio more than 30. Now, this usually occurs because the blood gets broken down and absorbed in the small intestine, leading to a high blood urea nitrogen level. And also because of the loss of blood in the vomitus, there can be reduced perfusion to the kidney. So all of this can result in a bun to creatinine ratio more than 30. Now, on the other hand, the presence of blood clots in the stool or frank blood or hematochezia makes a lower GI bleeding more likely. So this quick assessment is very important to find out the possible cause of the bleed. After this quick assessment and stabilization of the patient, an urgent upper GI endoscopy has to be done within 12 hours. In that endoscopy, you will check if the source of bleed has been identified or not. If it has, then we go for the specific therapy for the cause, of which I'll be talking about in a minute. But suppose the source of bleeding is not identified, then you'll have to think of other causes like of lower GI bleed. So we take a colonoscopy, And if the source of bleed is identified, then we'll go for the specific therapy for that cause. If it's not, you'll have to go for further investigations like CT angiography or push enteroscopy. Now, this is a very important chart, that is the decision on when to transfuse a patient with upper GI bleed. Indications for transfusion: first is a hemoglobin less than 7 gram per deciliter, or active bleeding and hypovolemia, hemodynamically unstable patient, a hemoglobin that is less than 8 in a patient with comorbidity like heart disease, for example. In all these three cases, you have to transfuse packed red blood cells. And in case of severe ongoing bleed, we go for a 1:1:1 massive transfusion protocol, where we transfuse RBC, plasma, and platelets in the ratio 1:1:1. For platelet transfusion, we generally transfuse if the platelet counts are less than 50,000 with active bleed, or if the platelet count is less than 10,000 per ml, regardless of the symptoms. So these are the various indications where you have to transfuse blood products to a patient with UGI bleed. Now, what are the common sources of upper GI bleed? I have divided it into esophageal causes and gastric causes. Esophageal causes are variceal bleed in a patient with portal hypertension. That hypertension could be because of alcoholic liver disease, liver cirrhosis due to various causes like hepatitis, non-alcoholic fatty liver disease. Then esophagitis. For example, pill esophagitis is what happens while taking medications like iron or KCl. And you can also have infectious esophagitis. All this can lead to upper GI bleed. And Mallory-Weiss syndrome. So these are esophageal causes. Gastric causes include peptic ulcer disease and gastritis, which could be H. pylori induced or because of NSAID use, or it could be because of a malignancy like gastric carcinoma. Coming to risk stratification. Now, for patients with UGI bleed, we have to identify patients with high risk or low risk, for which we use two important scores. One is the Rockall score and the other is the Glasgow-Blatchford score, or GBS. Rockall score considers the following, that is age, the presence or absence of shock, presence of comorbidities, and endoscopic stigmata. These are features that the score takes into account, whereas the GBS score has other few features that they take into account, like blood urea nitrogen, hemoglobin, systolic blood pressure, pulse rate, presence or absence of melena, syncope, and presence of comorbidities. Now, the thing here is that the Glasgow-Blatchford score does not include the presence of endoscopic stigmata. So when a patient initially comes in, you can use a GBS score to quickly stratify them, whereas a Rockall score includes endoscopic stigmata. So you should have done an endoscopy before we can give a Rockall score to that patient. Now, coming to further management of variceal bleed. So in this slide, I'm going to focus on management of a variceal bleed. And before we move on into the specificities, I would like to define a few terms. So an acute bleeding episode is a bleeding event that occurs within the first 5 days from the time of admission. The second term, that's early rebleeding. Early rebleeding is one that occurs after 5 days but less than 6 weeks from the time of admission. And late rebleeding, that's third term. This is the one that occurs after 6 weeks from the time of admission. So we have the first 5 days, that's acute bleeding episode. 5 days to 6 weeks is early rebleeding. More than 6 weeks is late rebleeding. So for a patient with variceal bleed, assess the patient's status. If the patient is hemodynamically stable, you can proceed with an upper GI endoscopy. But if the patient is unstable with active bleeding, then we go with something called the balloon tamponade, or using something called the Sengstaken-Blakemore tube. So what is this? Now, balloon tamponade, please note, is done only for temporary stabilization until definitive treatment can be done, because there is a risk of rebleeding after deflating the balloon. So this is a picture of the Sengstaken Blakemore tube. So after this tube is placed, this is the gastric balloon. The gastric balloon is first inflated around 100 ml, and then you take an X-ray to make sure that the positioning is proper. After confirming the position, we further inflate the gastric balloon till about 350 to 400 ml, and then we gently pull on it so that the balloon stays tamponading the gastroesophageal junction, and most of the varices is in the GE junction. Now, usually with just the inflation of the gastric balloon, the bleeding usually stops, but if it doesn't, then we go ahead and inflate this esophageal balloon as well. We inflate it to about 30 to 45 millimeter of mercury pressure. But the thing here is that we have to keep checking the esophageal balloon pressure like every hour, because excess pressure can lead to esophageal necrosis and eventually rupture. Also, the balloon has to be deflated, that is, the esophageal balloon has to be deflated every 12 hours to prevent necrosis. And in this process, if at all, while deflating the balloon, rebleeding occurs, that the whole tube has to be removed. And note, this Sengstaken Blakemore tube is just a temporizing measure until definitive treatment can be done. Alright, coming back to our chart. So, for an unstable patient, we have used a balloon tamponade, and once a patient is stable, you proceed with UGI endoscopy. On endoscopy, suppose we have confirmed that it is a variceal bleed, what we do is we have two options. One is an endoscopic band ligation or endoscopic variceal ligation, also called EVL, and the second is endoscopic sclerotherapy. So now EVL is what is preferred over sclerotherapy. In EVL, what we do is we place small elastic bands around the varices, while in sclerotherapy, we inject a sclerosant into the varices. And a newer method that is now being studied is called the SEMS, that is self-expanding metal stent. This is usually used for the management of variceal bleeding that's refractory. Alright, so we have seen the varix through the endoscopy. We have done either EVL or sclerotherapy. Now what happens? Now you have three possibilities. First is that there is no further bleed. Second is that the bleeding just continues. And the third is the bleeding stops temporarily, and then again it starts bleeding. After 5 days, a rebleed occurs. So in these three cases, what should we do? If there is no further bleed, case 1, you can initiate secondary prophylaxis, which is basically a combination of beta blockers plus EVL, that is repeat EVL after 2 weeks, until all the varices are obliterated, and then you'll do endoscopy every 3 to 6 months to monitor. So basically the main aim is to obliterate all the varices and then keep monitoring. Now the second option is, in case the bleeding continues, then you have to go for a balloon tamponade. And in the third case, that is early rebleeding, you could try a repeat endoscopic therapy. But in case the balloon tamponade and the repeat endoscopic therapy does not work and still there is recurrence of bleed, then what we go for as a final option is either TIPS or shunt surgery. What is TIPS? TIPS stands for transjugular intrahepatic portosystemic shunt. So what happens is, in TIPS, a low resistance channel is created between the hepatic vein and the intrahepatic branch of the portal vein. So essentially what we're doing is we're reducing the pressure within the portal system and channeling that pressure directly into the hepatic vein, which is in connection with the systemic venous system. And TIPS is what we prefer over a shunt surgery. And very important to remember, a very important major adverse effect of TIPS is hepatic encephalopathy. And other long-term measures that can be taken in case of failure of initial treatment apart from TIPS and shunt surgery also includes liver transplantation. Alright, now coming to the complications that can occur in patients with variceal bleed. So first is infections like SPP, UTI, pneumonia. SPP stands for spontaneous bacterial peritonitis. So because of the risk of infections, that is why we give prophylactic antibiotics in a patient with variceal bleed. Remember, we did talk about giving IV ceftriaxone or fluoroquinolones to patients with variceal bleed. The second complication is hepatic encephalopathy. So that is because of increased breakdown of the blood in the small intestine, leading to increased production and absorption of ammonia. This can be managed with lactulose. And the third complication is renal failure. Renal failure can occur either because of reduced perfusion to the kidney, leading to pre-renal AKI, or it can be due to the hepatorenal syndrome. So in hepatorenal syndrome, what happens is there is vasodilation, there's peripheral vasodilation because of various vasodilating substances that are released in case of liver damage, and that peripheral vasodilation essentially reduces the blood flow to the kidneys, leading to renal failure. And management of renal failure, especially in case of the AKI that occurs because of reduced perfusion, is essentially volume replacement. And in case of hepatorenal syndrome, we do start the patient on agents like terlipressin. Alright, now coming to prophylaxis. Now there are three important kinds of prophylaxis that we should consider for esophageal varices. So one is pre-primary, second is primary, and third is secondary. Pre-primary is prevention of varices from even developing in the first place in a patient with portal hypertension. In these patients, we just do routine screening endoscopies. We don't really start them on a beta blocker yet. Primary prophylaxis is the prevention of the first variceal hemorrhage in a patient who already has varices, or if they're medium to large varices, or if it's a small varix with a red sign, or a patient with a child B or C cirrhosis. In these cases, we want to prevent the first variceal hemorrhage, and that is primary prophylaxis, which can be done either using beta blockers or using endoscopic variceal ligation. Now note here that beta blockers must be started only after the patient is hemodynamically stable and off of vasoconstricting drugs. Beta blockers, what they do is they reduce the portal blood flow by reducing cardiac output. They also cause vasoconstriction of the splanchnic circulation because they're essentially blocking beta receptors, causing unopposed alpha-mediated vasoconstriction. So this reduces blood flow to the portal vein, thereby reducing portal hypertension. And when we use beta blockers, we reach the optimum dose of the beta blocker by reaching a target heart rate. We target a heart rate of around 60 or 55 to 60 beats per minute as optimal response to beta blockers. And for those patients in whom beta blockers cannot be used, cannot be tolerated, then we'll go for EVL. Now, secondary prophylaxis is a combination of EVL with beta blockers like nadolol and propranolol. So what we do here is we do an EVL 1 to 2 weeks after we discharge the patient. Then we repeat every 2 to 4 weeks until all the varices are eradicated. And we start beta blockers on day 5 after the initial bleeding episode. So secondary prophylaxis usually has both EVL plus beta blockers combination. Now, so until now I've talked about variceal bleeding and how to manage that. Now I will be talking about bleeding peptic ulcers. So in case of peptic ulcers, endoscopic findings can actually be classified into something called the Forest classification, and we call that stigmata of recent hemorrhage. So we say that stigmata of recent hemorrhage is present if we find anything on an endoscopy study that is anything but a clean ulcer base. So what I mean by that is, as per the Forest classification, we have 6 classes. 1A, that is spurting hemorrhage. 1B is oozing hemorrhage. 2A is a non-bleeding visible vessel. 2B is an adherent clot. 2C is a flat pigmented spot, and 3 is a clean ulcer base. So anything that is not anything apart from a clean ulcer base is going to be considered stigmata of recent hemorrhage. Now, patients are considered to have high risk of recurrent bleeding if they have a spurting or an oozing hemorrhage, or a non-bleeding visible vessel, or an adherent clot. Also, High risk for persistent or recurrent bleed is also seen with those ulcers along the lesser curvature of the stomach or the posterior duodenum because of their close proximity to large vessels. Also, patients who present with active hemorrhage, shock, low HP concentration, all of these are patients who have a high risk of recurrent. So high risk patients are those who are in class 1A, 1B, 2A and 2B, and the reason why we classify them as high risk and low risk is because patients who have a high risk of recurrent bleed require endoscopic therapy, but those who are at low risk do not require an endoscopic therapy. Alright. Now these are a few pictures of the endoscopic findings as per Forest classification. So this is 1A. This is the spurting active hemorrhage. This is 1B or oozing active hemorrhage. This is 2A, that is the visible vessel that is not bleeding. 2B is the adherent clot, and 2C is a flat pigmented spot. So these are a few pictures based on Forest classification. Now coming to the management of a bleeding peptic ulcer, starting off with pharmacotherapy, all patients with UGI bleed should be started on high dose IV proton pump inhibitor before endoscopy. So what we do is we first give a bolus dose that will be followed by an IV infusion. Then we perform endoscopy within 12 hours. Now if the patient has a high risk stigmata of hemorrhage on endoscopy, we continue the IV PPI for 72 hours as continuous infusion, and then we switch them to a high dose oral PPI. But on endoscopy, if there is absence of high risk stigmata with no active bleed, you can just put the patient on a standard dose of oral PPI. Now, apart from pharmacotherapy, we also have endoscopic therapy. Endoscopic therapy is required for ulcers that have a high risk stigmata of recent bleed or high risk of recurrent bleed. It is not required for ulcers that have low risk for recurrent bleeding. And just a note about adherent clots. Now, these adherent clots, the management is a bit controversial, but what we generally do is we remove the adherent clots with gentle endoscopic irrigation or suctioning in order to reveal the underlying stigmata of hemorrhage. And this has to be done only with a person who is equipped to do the removal of the adherent clots, and in case there is bleeding, that location of the ulcers should be such that in case a bleeding happens, you can easily stop the bleeding with endoscopic therapy. Now coming to the different types of endoscopic therapy that we use. So the first is thermal coagulation. In that there are two types, coaptive coagulation and argon plasma coagulation. Now coaptive coagulation is where pressure is applied to the vessel with a probe while coagulation is being done. So what this leads to is it leads to the sealing up of that vessel. And the second is APC, argon plasma coagulation, as I have shown in this picture. The second option is endoscopic clip placement. That is the picture that is shown here. Then injection therapy. Injection therapy is done with dilute epinephrine, and we usually don't do this as monotherapy. We combine injection therapy with either thermal coagulation or clip placement. Then a few newer, more options that are being studied now are fibrin sealants and hemostatic sprays. Now, apart from all of this, it is definitely important to note that all patients with bleeding ulcers must be evaluated for causes like H. pylori, NSAID intake, and those specific causes should also be treated. So that is with this video on upper GI bleed. Thank you, and I hope you enjoyed it.